Assalamu alaikum. Dear colleagues, good afternoon. It's my pleasure and honor to be between you. I will speak about C12 fixation techniques. I have no financial disclosures related to this topic. Actually, the indications, as Dr. Ahmed Saleh mentioned, C12 fixation or fusion is indicated in all causes of C12 instabilities according to the different pathologies: congenital, traumatic, inflammatory, like rheumatoid arthritis, infections, degens, and reconstruction after tumor resections. The two common approaches are the anterior or posterior approach, and sometimes we use combined approach, anterior and posterior. And the anterior approach, it may be high retropharyngeal approach or transoral transpharyngeal. And sometimes also for C2 odontoid screw fixation, we use the traditional anterolateral anterior approach. We will start, it's done totally under general anesthesia. Positioning, we can use the Mayfield clamp or we use the frame. We tend to put our patients in some forward inclination or flexion. This is more easy to achieve the trajectory of C12 fixation according to the screws used. Avoid venous congestion, because if the position of the head is below the position of the body, you will have some venous congestion, and that's why we put the head in some flexion. However, we put the whole table in some, we put the upper part of the body more elevated than the lower part, and ensure adequate fluoroscopic access. That's to check your trajectory in the lateral position with the image intensifier intraoperative before you start your incision. It starts with the skin incision, and then the whole paravertebral muscles are elevated in a subperiosteal fashion. You have to stick to the white line in the midline. This decreases the intraoperative bleeding significantly. And you dissect laterally until you reach the lateral end of the lamina of C2. For C1, we tend not to dissect laterally more than 1.5 to 2 centimeters. This is also to avoid injury of the vertebral artery. Regarding our fixation or anchor points, we have C1, we have sublaminar wires, or even some sublaminar suture materials. We use lateral mass fixation or direct screws. This is the goal harms technique, and the screws, we tend to do it bicortical. However, don't go far anterior because you are at risk to injure the internal carotid artery. C2 fixation, we have different fixation techniques or anchor points. We have sublaminar wires, we have bars screws, or the so-called Judet screw. We have pedicular screws, we have laminar screws, we have C12 transarticular according to Margar. This can be done posterior according to Margar, or anterior. This is also one of the common techniques. And we have the goal technique, or the C12 distraction fusion technique. This is the Gali. It's not used nowadays as a standalone technique. It's commonly combined with C12 transarticular or direct screws. I mean, goal harms technique. We fashion an iliac graft in this H shape, and we put it between the C1 and C2 after decortication of the posterior arch and the C2 lamina, and then you fix it with sublaminar wire. And actually, we commonly use Ethibond 5 as a suture material. We pass it sublaminar below the C2 lamina and also below C1 arch. And there are different techniques how to fix the wire or the suture material at the end of your procedure. This is the direct screws, C12 pedicle screws. As I mentioned, we tend to use bicortical screws at C1, and C2 fixation, it can be commonly, I mean, the described goal harms technique are pedicle screws. However, as I mentioned, we have different options of fixation in C2. This is the goal harms technique, and these are the different options on the right side. You can use pedicle screws and C2s. You can use bars screws or Jude, and they have the same trajectory. However, the Jude screw has the same trajectory like the Margal screw, but you don't pass beyond the C1-2 facet joint. And you can use the laminar screws if you have like abnormal anatomy of the vertebral artery. This is the entry point for the C1 direct screw. Actually, we tend to have like 5 to 10 degrees inclination to the midline convergence, and your direction in the lateral trajectory is controlled completely with fluoroscopy intraoperatively. And this is the standard entry point. As Dr. Ahmed Saleh mentioned, if you have a ponticulus posticus, sometimes you go through the arch. The standard entry point is below the arch, and sometimes you have to remove like a very small fragment of the posterior arch in the image below on the right side. You have to remove like overhanging part of the posterior arch just to have access to this entry point. And if you look here, sorry, I don't have a pointer. You have the vertebral artery on this one. Okay, thank you. It is very important to understand the anatomy here. You have a very rich venous plexus here. It commonly bleeds. And you have the vertebral artery on your lateral aspect. You have C2 nerve root caudal tube, and also the vertebral artery cranial to your entry point. And this is the projection of C2 pedicle screw. Actually, you have to feel the medial border of the pedicle through the spinal canal, and your direction craniocaudal is totally controlled with intraoperative fluoroscopy in the lateral view. We tend to incline about 20 to 30 degrees from lateral to medial. This is also the goal harms technique. And here is also the difference between a normal posterior arch on the right side above and the ponticulus posticus on the right side below. This is the Margal transarticular screw. It's also commonly used. And biomechanically speaking, C1-2 direct screws has the best biomechanical stability, followed by C1-2 transarticular, followed by the other different techniques. This is the direction of the Margal screw, and it's here combined with Gali also iliac graft for fusion. These are intraoperative. As you see here, we feel the medial aspect of the pedicle of C2 from inside the spinal canal. This is this blunt hook, and this is the trajectory. You are going just above the posterior facet of C2-3, and your target point is here, just posterior to the middle of the arch of C1. This is the interpoint, as I mentioned. You feel the medial aspect of the pedicle of C2, and you dissect laterally until you can feel also the lateral border of the lateral mass of C2, and midway between the medial border and the lateral border, you identify your interpoint, just cranial to C2-3 facet. Actually, as a tip, you can put like a dissector in C2-3 facet to gain the direction of the facet. And laterally, you are completely controlled with fluoroscopy. This is position of the patient again. And to achieve this trajectory, we commonly use just 2 stab incisions distal to the incision that we made for the surgery. Because if you want to introduce the C1-2 Margal screws through the same incision, you will have a very large incision in many cases. And that's why we use like 2 stab incisions at the cervicothoracic junction. And here you can control your interpoint under vision. And of course, under lateral fluoroscopy, you can drill your, you make the hole and then put the screw. This is what I mentioned. And at the end, you will have about 4 to 5 centimeters just between C12 vertebrae and the 2 small stab incisions. And here we combined it with Gali, and here we used the sublaminar wire or Atlas cable. Another case, actually thanks to Dr. Mahmoud Fouad, this is one of his cases. He didn't remember him, but this is one of his patients. 68 years old man, he fell on the ground and he has incomplete spastic tetraparesis. And you can see here myelopathy at the level of C1, and also we had a pre-op MR angio, and the patient had high riding vertebral artery. It's not clear here, but you can see here, this patient in the lateral view, you can see this is high riding vertebral artery. You have no chance to go like for Margall screw or even Judet screw. Also on the other side, and also it's completely apparent anatomy. You cannot put pedicle screw in this C2, whatever at which level you try to do it, okay? And that's why he used sublaminar wires, direct screws C1, and sublaminar wires, and intralaminar screws at C2. Remember him? Okay. Another patient, this is also one of my cases with Professor Shawky. This patient was presented with a craniocervical anomaly with atlas assimilation. C1 arch is completely fused to C1, and also with cranial settling. He was operated at a younger age from our colleagues in neurosurgery with posterior laminectomy, and he has like a very kyphotic deformity at the subaxial spine. He was operated in 2 stages with first multiple level ACDFs to correct the subaxial spine. And then we went for what we call a C12 distraction fusion according to Goel harms. And this is what Professor Assam Sharif just mentioned. We put 2 cages between C1, or at least the assimilated C1 and C2. We used the small cervical cages, standardly used for ACDF. And you can see we could achieve very good reduction of the dens outside the foramen magnum without foraminotomy of foramen magnum. Actually, this image shows the different techniques used for C2 fixation. This is the commonly used odontoid screw, and as you can see, the transarticular or Margall are here in the lila, purple color. We have the Barza screws, we have the laminar screws in orange, and the C12 joint screws in red. My take-home message, C12 should be fixed in low doses. Just for our younger colleagues, the angle between C12 is about 25 to 30 degrees of low doses. And you have to correct it intraoperatively more or less to this level. CT angiography and the MRI are mandatory for preoperative planning. Choice of fixation technique depends on patient's anatomy, surgeon's experience, and available infrastructure. These techniques are more or less standard worldwide done under navigation, and posterior approach is the gold standard. Many thanks.